right, welcome back. So now we're going to go into some exercise precautions for cancer patients. So in this presentation, we're going to go through some key precautions related to chemotherapy, radiotherapy, hormone therapy, surgery, and then some disease progression considerations. But ultimately, the main thing I want you to remember throughout this presentation is these are just the key ones that I've seen quite a bit out in practice. And they do obviously vary quite a bit from individuals. So if you ever have any big concerns with someone you're seeing or you're just really unsure, refer out or just get them to contact their GP. As always, you're better to err on the side of caution. So to start off with, chemotherapy is probably one of the big ones that come to mind when I think of side effects related to cancer treatment. So I'm going to highlight a few on this diagram, but just having a quick look at this diagram, you can see the number of different side effects that are associated with chemotherapy. And chemotherapy is very common to see patients go through while they are undergoing cancer treatment. As a bit of a background, chemotherapy is a drug treatment for cancer that kills fast-growing cells. So yes, that targets cancer cells, but that also targets the healthy growing cells in the body. So hence why there are so many different side effects associated with it. Some of the key side effects and precautions I'm going to touch over are on this slide. One being brain fog, or otherwise known as chemo fog. So a lot of patients describe this as a complete just confusion, difficulty remembering simple things, short-term memory loss, kind of a very severe version of how we would feel when we've had a poor sleep, a very busy day, but that's every single day for these patients, and there is nothing they can do so much to relieve those symptoms. So for us in practice, we would be looking at how we're going to make these appointments easier for our patients. So making sure they've got reminders of when their appointments are, if you're sending them home with a home exercise program, having pictures, photos, etc., just to help relieve some of the stress associated with that. Next, we're going to jump across to hair loss. So quite a few patients do find that hair loss is a side effect of different chemotherapy agents. And this can be particularly distressing, especially for women, as quite often women have long hair. It can be part of their identity. And quite a few patients can find it quite scary and a bit intimidating when they start to notice hair loss. So again, exercise isn't going to change anything in that respect, but purely just being aware of hair loss and being quite supportive and sensitive to those issues is important. Next, I'm going to jump down to the lower blood cell count. So particularly hemoglobin and anemia. I do find that anemia is quite common with cancer patients. So meaning a low hemoglobin count, being below 100 grams per litre, it classifies someone as anemic, but then also they're contraindicated for exercise if they drop below 80. Now, it's not uncommon to see people drop below 80 with their hemoglobin levels. I've had a few admitted into clinic before, and we've had to send them home, or I've had people that are kind of borderline, right up like low 80s, which then you can still exercise these patients, but you want to be very cautious. So ideally seated exercise, you're not going to be targeting that vigorous intensity. Really, anyone who's anemic, so below that 100 grams per litre, I would keep below vigorous, so in that moderate range as tolerated, pretty much. But obviously the low hemoglobin levels are quite important to know about because exercise, we require oxygen. Hemoglobin is the main part of the blood that carries oxygen around the body. So explaining that to patients, because quite often once they do learn the benefits of exercise, they won't want to stop exercising, or especially patients that have a bit of a stronger fitness background, they might feel fairly okay at rest. And we need to remind them of the risks of if someone was to pass out or require an ambulance in that situation. Next one I'm going to jump down to is bone loss. So osteoporosis, osteopenia, we know they're a big risk factor, especially for older populations. And this can be worsened with chemo. So we want to be aware of any fracture risks, looking out for red flags if someone is noticing a loss of bone mass, and if possible, having those bone mineral density scans quite regularly. And if they do have a family history or a pre-existing diagnosis of low bone mineral density, we want to be aware of that, providing bone loading exercises where we can. Moving across, we're going to go into loss of appetite. So quite often chemotherapy can impact a patient's appetite, making them feel quite nauseous, unwell, all of those things that make them not super keen to eat. But again, as we know, proper nutrition, hydration is very important before exercise. And then coming back into the education standpoint that they need to eat something, even if it's small, prior to exercise to make sure they don't have any adverse outcomes. You can always refer to a dietitian if someone's really struggling in this side of things. And that's a key area you'll want to pay attention to, especially for any head and neck cancers. As another kind of education point, reminding them that we need to build muscle mass for the body to then avoid sarcopenia and the strength benefits, that if they're not eating and they're not fueling their body, they're not going to have those same outcomes. And that kind of ties into the nausea and vomiting. As a side note, anyone who's undergoing chemotherapy, typically it's within 2 to 4 days post-treatment, but as a general rule of thumb, I just say from when someone's starting chemo to when they finished chemo, their bodily fluids are considered cytotoxic. So meaning if someone was to vomit, that vomit would have some level of cytotoxicity to it, meaning if we touch that with our bare hands, we are getting a dose of that chemotherapy drug as well, which obviously can be quite harmful. So for the patient's sake, we don't want them to have to be feeling really nauseous and vomiting through exercise. But if you were in a scenario where that had happened, you would want to be making sure you're wearing proper PPE, so gloves, mask, and cleaning it up with hospital grade wipes and alcohol. Next one up, we're going to jump across to the weak heart. So the next slide, we're going to go through this a little bit more. But chemo impacts the heart muscle and its contraction directly, which again, I don't need to explain to you guys why the heart's important for exercise, but it's something we need to be aware of and just screening for any of those red cardiac flags. Beautiful. So I think we might move on from there to cardiotoxicity. So it's pretty much a form of heart damage from certain cancer treatments, being chemotherapy or radiotherapy, particularly radiotherapy to the chest wall, particularly on the left-hand side. So any left-sided breast cancer patients often have radiotherapy there. It's quite good with how much you can target it, but you can't avoid any kind of heart effect. So it's something we want to be aware of. But this can impact the heart muscle, cause coronary artery disease, pericarditis, pericardial effusion, and then also impact the heart rhythm, all of which are quite important when we're exercising. And typically, if any of these patients are experiencing any cardiac loss of function or risks, they will be seeing a cardiologist at the same time. Another side effect of chemotherapy includes chemotherapy-induced peripheral neuropathy, or otherwise known as CIPN. So this is a pretty nasty side effect of chemo where a patient may lose function in the peripheral nerves of their body, so particularly in their hands and feet, but it can move all the way up their lower legs, up into their arms. And this can cause burning, pins and needles, pain, numbness, as well as quite a few other ranges of symptoms. So I've had a patient who, for the last better part of a year, reports that just at all times under the soles of his feet, it just feels like he's walking on rubber balls. So it does vary quite a bit from patient to patient, but you can imagine the significant impact it would have on their function and their physical activity, and their capacity to walk around if you can't feel your feet or you're in quite a lot of pain at all times. Unfortunately, this peripheral neuropathy can affect up to 40% of cancer patients undergoing chemotherapy. And it doesn't stop typically when chemo ends. It can last often quite a few months and sometimes several years after chemotherapy has ceased. So, in that sense, the main things we want to look out for are if you're seeing someone who is undergoing chemotherapy and starting to experience these symptoms, make sure that they report them to their oncologist, because the oncologist sometimes makes decisions to pull back on a few chemo doses or have a bit more time between chemotherapy trials, purely just to help the patient recover, and hopefully not develop these really long-term symptoms. And then also, as we would expect, their balance and their ambulation is going to be quite heavily impacted. So as EPs, we can prescribe exercise to help prevent too much of a loss of balance, making sure hips, ankles, core, they're all stable, nice and strong. Also benefiting the patient's confidence with walking. Unfortunately, there isn't a whole lot of evidence behind exercise reducing peripheral neuropathy symptoms, but we definitely can play a role in reducing the negative outcomes of peripheral neuropathy. Okay, next we're going into some bone metastases. So this occurs when a cancer cell migrates from the original site, and then migrates to the bone. So it can be any bone in the body. There are some key areas which are more common, like the spine, long bones in the legs, and hips. And it can happen with any form of cancer, but are particularly common in breast cancer and prostate cancer. Now, with bone mets, there are typically two different types, and sometimes you can have a mixture of the two. So the first one's osteolytic, where you can see it's kind of characterized by a loss of bone mass. So you can see there's kind of this hole here which can occur. And the second is osteoblastic. So that's where a greater bone deposit grows. And that can happen between joints. It can happen on smooth surfaces of bone, which you can imagine both are quite negative in terms of cancer progression, because you lose bone strength. They can be quite painful, especially in the spine. They can press on spinal nerves, etc. And ultimately increase the risk of pathological fracture by quite a bit. So it's a big area that we want to be cautious with when exercising patients with bone metastases. Bone mets can be treated with radiotherapy directly, but this can also weaken the bone for up to 4 weeks. So if you're aware of a patient undergoing radiotherapy to their bone met, I would avoid that area for at least the 4 weeks, especially any end of range movement, impact, anything like that, because a pathological fracture, thinking hips, femurs, spine, can be hugely detrimental for these patients. Now, this gives you a bit of a better idea of what they might look like on scans. Not that we'll be getting these directly, but you can see here we've got an osteoblastic lesion, which is right up in that hip joint. So in this area, we would not be doing any end of range, deep squatting, heavy impact, jumping, leaping, bounding. This patient's sporting days would probably be over, and we'll be wanting to watch out for any red flags. So meaning high pain, sudden pain with movement. Any in this demographic, any movement that causes pain to the area you know has a bone met, we avoid. And this one over to the right-hand side is an example of an osteolytic lesion. So you can see there's that darker gray area in the bone, so kind of higher end of the humerus, where there's quite a bit of weakness through that bone now. So you'd be thinking about muscles that attach there, thinking about movements that then impact this bone, and how you're going to reduce the amount of impact and risk of fracture. So before we move on from bone mets, a few key things it's important to know are bone mets can progress quite quickly, depending on how aggressive the cancer is. And a progression of a few millimeters can make a huge difference in what risk they are out of a pathological fracture. So even if a patient has had recent scans, if they're showing that they've got a bone met somewhere, do not assume that it's still the same size or hasn't progressed at all in a week, 2 weeks, 3 weeks, because this can happen quite rapidly. As I said, pain at the site of the bone fracture is a big red flag, and any exercise causing this sort of pain should be reduced and refer back to the oncologist. If you're exercising someone who does have cancer and you're worried of a potential bone met, you're always better to re-refer, send them for a scan and make sure that there's no big risks associated with that. So ultimately avoiding torsional force, so that rotation, end of range flexion, and high impact exercise at all of the bone sites is important. And ultimately just be cautious, as this can have a very bad outcome if someone is to undergo a fracture. Alrighty, we're almost halfway through this one. Carrying on the radiotherapy side of things, radiotherapy can cause some pretty nasty skin burns, especially if they undergo quite a few fractions of treatment. So this picture on the slide shows a man who would have some form of head and neck cancer, and he's got some pretty severe burns through on his face, on his neck, which this can start to show up about 2 weeks into radiotherapy, but they tend to last for quite a few weeks to months after treatment. So if you know that your patient is undergoing any radiotherapy treatment, you want to make sure that they know how to look after their skin, which isn't particularly an EP area. There are some physios that do further training to become scar specialists, and they're great to refer to. If you do ever have anyone in that realm, I know a few, so I can help you do a referral. But you want to make sure that they have had some guidance on how to look after their skin and who to see if they are having any issues. In terms of an exercise perspective, we're just looking at avoiding any friction and pain associated with that area, which something like the neck is a bit easier to avoid, whereas breast cancer patients, prostate patients, anyone who has radio to kind of more or less the body, that can be a little bit more tricky with, and we just need to listen to how the patient's feeling and what is working for them on the day, really. Okay, next is lymphedema. So if cancer has spread to the lymph nodes, they will often have them removed, or some form of radiotherapy, but that can negatively impact the body's capacity to pump around that interstitial fluid. Now, there's several different stages. As you can see, stage 1, can't really see a big difference between sides. Stage 2, you can see that arm is starting to swell compared to the other side. And stage 3 and 4 are quite obvious, where you can see that fluid doesn't have too much of a capacity to flow back into the system and then circulate throughout the body. So the main thing to think about with lymphedema are the red flags of is this person at risk of developing lymphedema? So if you know someone's had their lymph nodes impacted by their cancer or impacted via treatment, so some people have lymph nodes removed as a precaution, they should always be referred to a lymphedema therapist where they'll do a DEXA scan. So you just stand on a special scale, tests all of the fluid around your body, sees if there's any difference between sides. So it's a pretty easy screening to do. But gold standard, you want them to do it pre and post surgery, and then every 3 months from then. For those who do have lymphedema, it is really important to exercise the area. Even though, again, one of the initial kind of standpoints was to leave the arm alone because it can be quite uncomfortable. We do want to be exercising, especially if they do get prescribed a lymphedema garment, as our muscles can work as an intrinsic or an extrinsic pump to circulate that lymphatic fluid. Now, surgery precautions. So obviously there are endless amounts of surgeries associated with cancer, but I've touched on two of the main types of surgeries that I've seen in practice anyway, and probably the ones that have some of the biggest precautions in terms of exercise. So mastectomies are very common in breast cancer patients, with 50% of women choosing to undergo reconstructive surgery where possible. So these are two different types of reconstructive surgery. This can involve implants or a tissue graft from another area in the body, which you can see in this bottom demonstration. It's a lat dorsi flap that they've taken from one side and then placed it where the old breast tissue had been after a mastectomy. And then over on the top, we've got what's called a dip flap. So they take some tissue from the lower abdomen and then as well as blood vessels, skin, and then we move it up into the breast area. So this provides the same sort of sensation as a woman would have had, or look more so, prior to their mastectomy. And quite a few women will choose to go through this so that they can kind of move past the changes to their body after cancer. However, you can imagine when you're doing any sort of tissue, muscle, etc., graft, it's going to weaken two areas of the body. So yes, the breast tissue, which has already undergone quite a bit of treatment, but also these patients will have some weakness moving forward from the different areas that they've taken that tissue from. So ultimately, this won't typically be the EP's role. They'll usually see a breast care nurse and physios that work particularly in the area, but once these patients do begin exercising, we want to continue being cautious of any red flags. So soreness, pain, seromas, which I'll go into the next slide, and just gently working up in their range of motion in particular. Now, unfortunately, some patients do also notice that the tissue graft isn't successful. So I've got a lovely lady who I've seen for a while now who's had 2 lat dorsi flap reconstructions, and both of them failed. So now she's going for an artificial implant, which can obviously be quite mentally draining and difficult to manage when you've already gone through a cancer diagnosis and treatment itself. But yes, that's a very, very brief overview on surgery precautions. Treat them like any other musculoskeletal surgery. So consider how long it's been post-op, consider what they're doing prior. They'll typically see a physio for some passive and range of motion work first, and then just looking out for the common red flags of high amounts of pain, and then go from there. But I do apologize. That's a very brief overview on surgery precautions. but you'll get a better referral if you were going to see someone kind of with anything too soon post-op. Alrighty, like I said, seromas, they're the most common complication with breast cancer. So it's where a form of fluid may build up under the skin where the tumors or surrounding tissue were cut out previously. This can happen naturally or due to the patient doing some away from body movements too early post-op. So if a patient was reporting any sort of seroma-like symptoms, you would want to send them to the specialist as soon as possible, and avoid some upper limb loading until it's well managed, purely because seromas can keep on happening and then that impacts their healing process as well. Okay. Sarcopenia and cachexia, we kind of talked about this a little bit prior, but sarcopenia is a loss of skeletal muscle mass and strength, which is usually associated with aging. But then cachexia is defined as a weakness or wasting of body tissue due to severe chronic illness. Both of them can be quite common in the cancer space, unfortunately. And the cancer treatment can cause both as well. Bear in mind, sarcopenia can be quite common in old populations. So unfortunately, some patients we may see may have sarcopenia prior to a cancer diagnosis, which then can just have compounding effects. Cachexia cannot be treated, unfortunately, and around 50% of people have the condition treated. So once that diagnosis occurs, there is no fix for cachexia. We're just avoiding as much weight loss as possible. So we want these patients to be seeing a dietitian, engaging in strengthening exercises, and making sure they're not losing weight too quickly. So the statistic at the moment is around 50% of people with cachexia die within 18 months of diagnosis, which is a pretty alarming statistic and something we want to try to combat with exercise as much as we can. So coming back to that original exercise medicine dosage of the 75 minutes of vigorous or the 150 minutes of moderate cardiovascular activity and then the strength, in these populations, we would focus a bit more on the strength. There's still absolutely a time and place for the cardiovascular exercise, but you want to really prioritize the strengthening sort of work to build that muscle mass. And you can also target your cardiovascular training to elicit a bit more of a muscle growth response. So rather than getting someone to cycle really quickly at a high RPM on a bike, you may ramp up the intensity with the resistance and keep the revs a little bit slower so you can get a bit of a mixture of the cardio and the leg strengthening side of things. Oh, look at that. We're at the end of the longest one. So I hope I haven't lost too many of you there. But like I said at the beginning, there's a lot more precautions than what I've talked about today. And the main thing to remember is if you're unsure, refer out. If you're noticing any red flags in any of those areas, like post-operatively, bone mets, etc., you can still exercise other parts of the body. So ultimately, we want to make sure that the patients are safe, but still benefiting some form of exercise treatment. Cool. I'll see you in the next one.